Well, hi again. This is Cherry. Just wanted to spend a little bit of time with you today talking about communication systems to include our documentation and our radio communication. So let's jump right into this, shall we? Okay. Our communication in EMS, we use a lot of different systems. So we use radios, handheld radios, radios that are installed in our vehicles. We use one-way pagers sometimes, especially with our volunteer services. We have a pager that will page out a call, allowing the responders to know where they need to respond to, but there's not two-way communication. We also use cell phones a lot. That's a protected private means of communication. With our today's society and the confidentiality laws that we have to adhere to, cell phones have become a very nice way to communicate because we all have one, and it's a private way. We don't have to disseminate patient information over the airwaves for everybody in Scannerland to pick up. And then, although not used too much anymore, we do have our traditional landline phones that we can use to communicate. Okay. So in our EMS radio system, there are several components of this system. We'll talk about those just a little bit, but they consist of base stations. Base stations are typically bigger stations that are mobilized or are located in stationary places such as dispatch centers or hospitals. And they don't go anyplace. They stay in one place. They have more power than our mobile systems and can have a farther communication area than our portable radios. But we do have our mobile radios that are in our squads, and those typically reach out a little farther than our portable radios. They are subject to location, so you're going to have some areas that have better communication, such as on the top of a hill, where you can reach out and don't have as much structure impeding your radio waves. Probably less ability to reach out farther with your communication if you're down in a valley or in a place that doesn't have a lot of good airway traffic. Then we have our portable radios, which we typically carry with us on our person when we get out. They're similar to walkie-talkies, but have bigger and different bands on them. And portable radios reach out as not as far as the mobile radios, and by far not as far as the base stations. Repeaters are another element in this, and I'm going to show you just very quickly in a minute on a diagram how those repeaters work. But repeaters are designed to pick up a signal and pass it along, move it along, and maybe give it a little more power to go on to the next station. We talked a little bit about cell phones, and the last component of our communication systems is telemetry. And telemetry is associated with our EKGs and a lot of our monitors. Paramedics specifically will be, and some EMTs will be doing 12-lead EKGs in the field on a patient and using telemetry as a method of passing this information or the results from this 12-lead EKG to a physician in another location so that they can look at it. So telemetry is often done over the phone lines, but it passes the document. So it'll pass that 12-lead EKG document over the phone lines, and it'll print out on a printer on their end so the doctor can see what that is. It's really very cool. Okay. So here we have our portable radio that we carry with us when we go out. So it doesn't reach terribly far, but if we can get it to a repeater, if our short, low wattage communication can get to repeater, then that repeater can pass it along. So it will bounce to other repeaters and or to base stations that are there. So let's say here's our dispatch center here at this base station or at the hospital. The repeaters help us get our shortwave communication to those places that need it. In our squad is our mobile radio, and you can see here's the portable radio, has a short range. The mobile radio can reach out a little farther, so where you can't reach by your portable, you possibly could with a mobile unit. And again, that goes from your mobile unit to the repeaters and will bounce along. Now, some areas of the county or some areas of the state have much better service than other areas. I actually worked up in Denison, Iowa, up in Crawford County a number of years ago, and Omaha is about an hour and 15-minute drive from Denison, and we could be sitting at the hospital in Omaha, and here are the next crew get paged out. So that particular area had a great ability to reach out because of the location of it. I actually lived in Shelby County. I lived down in a little hollow, and I struggled desperately to get my pager to even get the pages to send me out. So it really varies, and you need to know what your limitations are with your communication. So our radio communication is regulated by the FCC, or the Federal Communication Commission. They actually issue licenses. They establish the frequencies, or the radio bands, that we can talk on. Different bands are designated for different things. Some radio bands are designated for school bus traffic. Some radio bands are designated for airline traffic. And we have ours that are designated for EMS and law enforcement and those types of things. So you want to make sure that you know what your radio frequency is that you'll be communicating on. It also establishes the rules regarding proper language. So foul language and cursing is absolutely not allowed and will get you in a world of hurt. So if you're prone to using some four-letter lingo, practice not using it, because it will get you in a world of hurt when you're talking on the radio, especially if it's in an area where it can be heard for quite a distance, because there's no secrets then. And the FCC does monitor radio traffic, so if there's ever an infraction, you can get a fine levied because of the etiquette or the rules regarding the communication. So let's talk very quickly here. There's a whole list of things that we need to consider when we're talking. So we need to make sure, number one, your radio is on and that you don't have a ton of background noise. So if you're talking while you're driving down the road, make sure your window's rolled up and you don't have a lot of air noise going back and forth. You need to listen and make sure that there's nobody already talking on your frequency before you start. If you key up and try to communicate while somebody else is talking, the listeners are only going to hear one of you. They will not hear both of you. And generally it's the first person talking that they're going to hear. So we're going to push the talk button on the side of the radio and then wait at least 1 second before speaking. It takes a minute for that connection to connect before you're going to be heard. So you don't want the first part of your sentence to be cut off. We're going to put our mouth about 2 to 3 inches away from the microphone. You want to get close enough that they can hear you, but you don't want to be so close that you're rubbing your lips on the microphone. First of all, that's gross. Secondly, it creates a muffled tone. So when we first initiate our radio contact, we're going to name the person that we're trying to contact and then identify ourselves. So I would say, ER, this is Medic 3, or dispatch, this is Medic 3. And it's always in that order. So if the unit you're talking to tells you to stand by, that means that they're busy, they can't take your communication at that time. They will let you know when they're ready to hear from you. So you just need to wait until you hear from them. They'll probably key back up and tell you to go ahead. So always speak slowly and clearly. We want to keep our transmissions brief, 30 seconds or less. If you have more to say than you can get in 30 seconds, then you need to pause. Unkey your mic, allow anybody else to jump in that needs to, and then re-key up and continue on. because these are emergency traffic that's going to be going on there, that we don't want to monopolize the frequency so that other people can't get in there. Something that has changed in recent years is we don't use 10 codes. We're going to use plain English. So we used to speak in all kinds of code language, and we thought it helped keep the privacy down and people really didn't know what we were talking about. But since people now have scanners and they all have copies of our 10 codes, it does not work that way anymore. So we just use plain English because that decreases the chance of us being miscommunication or using the improper code. So we don't want to use things like be advised. We don't need to use please and thank you or you're welcome. Those politeness phrases are assumed and they take up radio traffic time. So the one code that we do use frequently is 10-4 because 10-4 acknowledges that we understand and heard them. So when we do numbers, we need to be very sure that we are clear. If I say 15, sometimes 15 might sound like 50 or 16. So I want to say we will be there in 15 minutes, 1-5 or 1-5 minutes, so that they are very clear what we mean. Okay. We don't want to say anything over the radio that would in any possible way indicate who our patient is or divulge any personal information about our patient. So never a name, probably anything that would incriminate, who they are, won't go over there. Absolutely no profanities or slander for anybody at all. So we're going to use objective and impartial statements. For the most part, we are giving facts over the radio. If it's an opinion, you need to think long and hard before putting it out there. Since you're part of a team, we always say we. We are en route to, we're at the scene, we are on our way back to you, because we're always a team. So we don't say I. Okay. So negative is preferred to saying no. And if I want to, affirmative or 10-4 is an acknowledgement that you understand or you heard. Okay, so we're going to give assessment information about our patient, but we're not going to put in our field diagnosis because it comes across that we're telling the doctors what their job is, and that is not what we intend. So I would say, like in this instance, patients complaining of abdominal pain, rather than the patient probably has appendicitis. Okay, I want to give them the facts, not my opinions. Okay, so I'm going to avoid slang, and I'm going to avoid abbreviations if at all possible, and stay on the frequencies that are dedicated to EMS. Okay. Oftentimes a 911 call comes in from a telephone, but can be coming through another agency. So we want to make sure that our information is all concise and clear so that we end up at the right location. I was in Colorado, where I was living for a couple of years. I witnessed a motorcycle wreck in front of me, called 911, but for some reason, because my phone was out of Omaha, when I called 911, it routed me to the Omaha Dispatch Center. So I'm trying to give the location of where this patient is, and the dispatcher is terribly confused. And we finally realized that I am in Grand Junction, Colorado, speaking to a 911 operator in Omaha. So she had to route me back through to get me to the right one. So sometimes those things happen, and the sooner we can recognize them and get them fixed, the better. But being very clear about our communication helps. Sometimes dispatcher will repeat back what they heard from you. So if I say, dispatch, medic 2's on scene, she may say 10-4, medic 2 on scene at, and give me a time. And that's just confirmation that she's recording what I said. Okay. So they may say we always use 24-hour clocks, and I think you're probably familiar with this already, but we use military time. So military time is the same, excuse me, during the morning hours. After 1 o'clock, instead of going 1 o'clock or 1:05, it goes to 1,300 hours. So we have 900 hours, 1,000 hours, 1,100, which is 11 o'clock, 1,200, then we go to 1,300. Otherwise, it's very difficult to know which 1 o'clock we're talking about. So basically, we just add, in the afternoon, we add 12 to our number. So if it's 1 o'clock, we add 12 to it, we get 1,300 hours. And so dispatch may say 10-4 medic 2 arriving on scene at 13:24 and give us the time. Now, you probably don't need to write this down because you're going to be able to retrieve that from the dispatch center once your call is over to put it into your documentation. It's just a way for them to confirm with you. So every time you leave on a call, you should have a portable radio with you. This is your means of communication when you're outside of the ambulance, which will be a lot of the time, or when you need to communicate with other departments that may be responding, maybe law enforcement, maybe fire, maybe another EMS department that would be responding with you. Knowing that you're going to be using these radios for your communication and to make sure that your scene stays safe and that your patient care is done to the best of our ability, we need to make sure that we take good care of our radios. So maintaining our radios, making sure that the batteries are up to date, that they're not broken, that our speakers are good, and that they effectively transmit communication is pretty essential. Unfortunately, these radios are a little bit expensive to maintain, so I would encourage you to take good care of them. Don't put them in a position where they're going to be dropped or knocked off or fallen. I'm coming to you from personal experience. I set my radio. I was on call and wanted to take a shower, so I set my radio on the edge of the sink, and so I could hear it while I was in the shower. When I got out of the shower, I set my towel over on the sink and hit my radio. It knocked it off. It bounced off the edge of the toilet and right into the toilet bowl. And you can imagine how wonderful that was from there. So my speaker didn't work after that. I could talk, but I couldn't hear anything. So take good care of your radio. We are going to give reports. First of all, we're going to give reports to dispatch as we move along. So once they dispatch us, we want to acknowledge that we heard it. We want to let dispatch know when we go en route. So it would be dispatch medic 3. She would acknowledge, go ahead medic 3, we're en route. We're en route to the scene. And she would probably respond back with a 10-4 and the time. We want to let them know when we arrive on scene. We want to let them know when we leave the scene to go to the hospital. We want to let them know when we arrive at the hospital, and we want to let them know when we're available to go back into service. So keep in good contact with dispatch so they know where you are. This helps because if you ever need somebody to assist you, she knows exactly, or dispatch knows exactly where you are. Okay? Usually this is all done by radio, so can be done by cell phone depending on where you are, but the radio is the primary means for this. We also need to give a report to the hospital once we know what we have going. So if we've got a trauma patient, that's going to require more people, especially a significant trauma patient, to respond to this call to the ER. So they may want to get radiology there. Some hospitals don't have radiology and lab there 24/7. They may need to call in a second doctor. They may want to call a surgeon in to come there. So we need to give them a heads up as quickly as possible. Other things that may require a little more planning on their part would be heart attacks, cardiac chest pain issues, and strokes. We want to let them know when they're coming in because those are going to require special interventions and maybe surgery. So we want to give them as much time as possible. When we give our radio report to the hospital, it is concise. It is only the important information, and we want to be very clear. So here's in the back of the squad, an EMT giving her report by radio. This frequently is done by cell phone just because of patient privacy. But if you use a radio and that's your normal means, then make sure we do it well. Okay. We're only presenting the pertinent facts. We're not giving any of the fluffy stuff that they don't need to know. That can be done when we give our verbal report when we get there. Okay. So here's what we're going to do. Identify ourselves. Patient age and sex, what the chief complaint was, a brief history, the past major illnesses, if that's applicable, okay? And then we want to tell them about our patient, what their mental status is, vital signs, anything we found on the exam that is of concern, the treatment we gave, how they responded, and how quickly we're going to be there. So here's how this is going to go, okay? CCMHER from 43, okay? They're going to acknowledge that they heard us. Let's say we're en route with a 24-year-old male patient, chief complaint of chest pain. Upon arrival, we found patient had been running, had a sudden onset of severe chest pain. Patient has no past medical history. He's alert and oriented ×3. Baseline vitals show diminished lung sounds on the left side, blood pressure of 124/76, pulse of 112, respiratory of 30. Patient is sitting 86% on room air. We've administered 15 liters of nasal cannula. Patient's now setting 92%. We will be ETA of about 2 minutes. Okay, short, sweet, done. That's a lot to get. It's 12 things that we're going to hit, but if you just practice, we can get this done very quickly. There was a lot more that I assessed and did on this patient, but none of it was abnormal, so it's not going to be in this medical report to the ER. Okay. So when we're communicating with medical direction, which is the ER for most times, we're going to give information clearly, accurately. Sometimes at the end of your report, you'll say, do you have any orders for us? If they do, if they say yes, I don't know what they would give with that patient, but then I'm going to repeat those orders back for them, word for word, 10-4. So like they say, this isn't pertinent to this patient, but can you administer 324 milligrams of aspirin, PO, or by mouth? Then I'm going to repeat that back, 10-4, administering 324 milligrams of aspirin by mouth. That way, if I didn't hear them correctly, they're going to understand and be able to correct me before I create an error. If I'm unsure what they asked for, I'm going to ask them to repeat it to me. Okay? If it seems inappropriate, it is pertinent and okay to question that physician. And you don't want to say, are you an idiot? But you want to say, just clarifying, 324 milligrams of aspirin for a patient that weighs 85 pounds, or be nice and tactful, but it's okay to question. Okay, so when we get to our destination, we're going to give a verbal report to the medical care providers that are going to be taking over. Now keep in mind, we cannot turn this patient over to anybody that is a lower level of care than we are. So you cannot turn a patient over to a CNA. You can't turn a patient over to a front office person. You can't turn it over to an x-ray tech, a lab tech. This has to go to a nurse or higher. Okay, so we're going to introduce our patient by name. Make that personal connection. And I always say, Lisa, this is Samuel. And even if I don't know the nurse, they have name tags on them. So if I'm like, Lisa, this is Samuel, I've introduced them. They have a connection now. And then I'm going to go on with my report. So I want to tell them what my chief complaint was. Basically, I'm going to a little bit reiterate what I told them on the radio, but add in some of the stuff. If there was a history with this patient that I didn't include before, this is the time to do it. Okay. If there's anything that I found on the assessment, basically what I found in the assessment was the patient had chest pain and there was diminished lung sounds on the left. But I also noticed that the patient has later on when I was recessing had some pain on his left ankle, and the patient said he twisted his ankle earlier. Okay. And then if I took some vital signs right before I walked in, which you should, then I want to make sure that I let them know what the last set of vital signs are, in addition to what I reported in my radio report. Okay. So to do this, we have to communicate with others. We have to communicate with, first responders, advanced EMTs, paramedics, home health aides, hospice, family members, other nurses in the ER, physicians in the ER, lab techs, radiology. There's a ton of people we're going to be communicating with. Most of these people speak in medical jargon, so knowing your medical terminology is going to go a long, long ways with helping you communicate, number one, to talk to them, but more importantly, to understand what they say to you. So if you're a little unfamiliar with your medical terminology, spend some time and get to know that. It is the language that you're going to be speaking from now on. We're always going to be respectful, even if you don't agree or you're upset. And we're going to speak candidly. So we're not going to tell them something we really don't believe to be true just because it sounds good. We're going to be frank and we're going to be honest. But we can do that with tact and respect. Okay. What our goal is patient care. So we want to collect information about our patient and we want to communicate information about our patient using good techniques. You're going to learn how to communicate with patients. Some patients are easier to communicate with than others. If you get a psych patient, those are always very interesting, probably my favorite just because they're a challenge. Drunks are interesting. Kids are interesting. But how about somebody that's hearing impaired or somebody that speaks an entirely different language? Those are issues we have to come up with, and we kind of have to punt when we're on scene doing that and find a way to communicate with these patients. Our communication skills can always be improved. I have a few things that I like to use. Eye contact is absolutely critical. If you're not the person, I used to be married to someone who, although super guy, really good egg, did not ever make eye contact with people. And I don't know why, but he always, I think it's easier to believe somebody when they look you straight in the eye. So make eye contact. Don't make it so like, I'm staring you down and it's uncomfortable. But make that eye contact. Look them in the eye. Look them in the eye when they're talking to you so that they know you are interested in listening. Frequently look up and look them in their face. Look in their face. Look at their eyes and see how they're doing. It's easy to look at them when we first get there, and then we get so busy doing vitals and checking things we forget to look at them. But there's a lot that their face is going to tell you. Look at it and look in their eye and see how they're responding. A lot of times with sick kids, that's where we see it, is in their eyes. You see that fear in their eyes. So use that. Be aware of your body language. So I always like to be at, well, I shouldn't say always. If I am wanting to show compassion to my patient, I want to be at their level or below. So if I have Ethel that I'm taking care of and she's sitting in her recliner, I'm going to come up and squat down or kneel so I am at least at her eye level, if not a little below. That puts me serving her, and that's how it should be. Okay. Now, if it's a situation that I need to gain control of this situation, I don't do that. I'm not very tall, so I have a hard time towering over people. But I'm not squatting or kneeling or sitting at any point in time if I've got a scene that is not under control, in which case I may stand up on something. I may stand up on the bumper of the squad. I may stay in the back of the squad and open the back door so that I am taller and can look down over a situation. I may place myself on a curb or a embankment so that I'm higher and put myself in a position of authority. So, and then look at your body language. Look at how your arms are. I have a student that I have in one of my classes now, and her natural body reaction is always to fold her arms across her chest. I think that comes from a lack of confidence in her, but it comes across to other people as her being snobby and standoffish. It is not how she means it to look, but it's how it's interpreted. And really, what we have to look at is how are people going to interpret our actions. So make sure that you're speaking, your body language is saying things that you want it to say. If you're in doubt, have somebody record you or ask people, say, be very honest with me and tell me, how do I come across? And if you've got somebody that's truly your friend, they'll tell you, and then you can work on those issues. Okay? So don't use your medical terms with our patients. They don't understand them. They sound foreign and cold and confusing, and it increases fear. Use regular terms. Okay? Explain things that you're going to do before you do them. That way there's no fear element. They know what to expect, and they think they can trust you. And absolutely, golden rule, be honest. Okay? I never, ever, ever tell my patient everything's going to be fine, because we may get hit by a truck on the next corner. Okay? Or she may have a blood vessel in her chest that ruptures 5 minutes from now that I had no idea was even there. So never say that everything's going to be okay. But you can certainly say, we're going to take the very best care of you that we can. I've done this a long time, and I'm going to take really good care of you. And sometimes I tell my patient, you know what, you can trust me. I'll take good care of you. And it just sets them at ease. I've always told my patients that your patients really don't care how much you know. What they want to know is, how much do you care? If they believe that you care about them, they will trust you and cooperate with you. If you can't establish that trusting relationship, you've got a long uphill battle ahead of you. So make sure that you're able to do that. Same with kids, man. Don't lie to kids. They will pick up on that, and you have just lost every ounce of credibility you ever had. Okay? So use their proper name. I address all of my patients that are adult as Mr. or Mrs. Okay? Until they tell me differently. If I don't know what their name is, I ask them what their name is, and then I ask them what they'd like me to call them. And that I use that. Okay? It's a sign of respect, and it's also good communication. It gives you an open door to start talking to these patients. So we have to establish that trust, and we have to do it early. So this is a gal talking to her patient. You can see she's right down next to her patient, explaining the procedure and what's going to happen. Because I don't know about you, but slapping a big old mask on somebody's face isn't normal. So if they know what's coming, then they're not afraid. They understand why it's going to help them. Okay? Always be compassionate and always be respectful to all patients, but especially if they have a mental disability or they have an impairment of some sort or there's a language barrier. It's easy for us to kind of talk over the head of a mentally disabled person, or maybe not talk to them, talk to their caretakers. And they are people, and they need that communication, and they are just as afraid as any other patient's going to be when they get into a crisis situation. So same thing with our kids. Talk to your kids, and you might talk to your kids and then look up at mom to let mom answer. But include your patient in your communication always. Okay. If you've got a language barrier, I have become very good at pantomiming. Okay. I have a field guide that has some Spanish to English and Spanish to French phrases that are useful when I'm trying to get a patient history. Things like, do you take medications? I don't speak Spanish very well, so I speak a little French, but it doesn't do me much good in this area. But oftentimes I can have them read that. I can just point at it and have them read that, or have somebody else read it to them that speaks their language, and we can get that communication open. Pantomiming works. If that's all you have, use it. Okay? You feel kind of silly, but it gets the word across. Okay. Again, be very truthful to your pediatric patients. Okay, our pre-hospital care report. This is our written documentation, and this is really, really important because this lives eternally. So some forms, a lot of forms, especially in Iowa, are now done online electronically. So they're usually done on either a laptop or a tablet. Some departments probably still use a handwritten report where you actually have to write this stuff out. But whatever the form that your care report goes in, it needs to be accurate. Okay, so it's going to document our findings. It's going to document our treatments. We want to paint a very complete picture of our scene. Okay, because all of this is going to be entered into the patient's permanent medical record. It is a legal and binding document. So if you're writing this by hand, use a black pen. Okay, black ink is the acceptable method for a legal document. Blue ink is not accepted, not purple, pink, green, black ink. Okay. The other thing with art, it is a legal document. It can be subpoenaed into court and used as evidence. However, almost always when these things get subpoenaed in, it is anywhere from 2 to 9 years after the event happened. So if I'm expected to go into court and defend my patient care on something that I did 2, 3, 4, 5 years ago, I'm probably not going to remember the details of that. So if I go in there and my patient care report looks like it was written by a second grader, has spelling of a second grader, and doesn't list anything more than arrived on scene, loaded patient, transported to hospital, how do I defend that? And how do I even recall the scene well enough to be able to testify? So write every patient care report like you were going to be going into court with it, and you will never be sorry. Okay. Things that it can be used for: it can be subpoenaed into court. It can be used for insurance billing. It can be used against you in the case of neglect or negligence. It can also be used in if a patient is in a court trial and your care or something from the scene would be included as evidence. It can be used to help a patient win a case. Okay. Administratively, we use it for billing addresses and insurance information for billing. Okay. For education, we use this report for clinical research. Okay. So a lot of times, I sit at the state level in Iowa for the EMS Advisory Committee. What we see is we gather statistics. So statewide, we want to find out how much scene time, how much time are we spending on scene, because our deaths from trauma injuries are increasing. So what's going on here? Let's find out scene time, how much scene time we're spending. We can very quickly log into our electronic system that collects all of these patient care reports and pull up data that very quickly will spit out scene time. So we can sort it by scene times for ALS providers, scene times for, let's say, when a helicopter was transported, how long was our scene time? We can do scene times from rural counties versus urban counties. We can do data to find out how many times on a patient with chest pain are we giving aspirin, and this guides our education then. So if we find out, we've been on scene average time of 22 minutes for a trauma call, then we need to look at why and see how we can educate our people to make that scene time more closer to 10 minutes. If we're doing good on scene time, maybe we need to look at how, what our treatment is or how quickly we're getting vital signs on those patients, so we can determine where is the education most needed, and then we can target that. Medical directors can access this information. We can do it county specific, department specific. It does not give us, we don't ever release patient information. Excuse me. We don't release patient information when we give out these reports, and they only go to certain people that are qualified to have them, but they're valuable. There are also reports that you can pull up on yourself so that you can track how you're doing and where you need to focus your education personally. It also helps us with quality improvement. So as a department, we can look at, generally we set benchmarks. So it's like, okay, for the next 3 months, we're going to measure how soon nitro is administered after we arrive on scene at a chest pain patient. We're going to check how quickly a set of vital signs is obtained once we arrive on scene. And we're going to track scene times for trauma patients. And we're going to measure those for a period of time to see if we're meeting our minimum expectations or not. If we are, then we'll look at something else. If we're not, then we can develop a plan to improve that. Okay? So we have our standards set, and we want to always make sure that we're meeting our standards. So these patient care reports play into this continuous quality check system to make sure that we're not sliding on something or not meeting our standards. So things that are in this report are going to be your run data. Okay, so it's going to be who you are, the dates and times of the call, the unit that responded, what personnel responded on that unit, what level of certification those providers were. So that helps us determine what our minimum standards of patient care would be. It would be different if you have an EMT on scene versus if you have a paramedic. Okay. We're also going to use our official times given by dispatch so that the report from dispatch is going to match up with the report from the EMS. So before you do your run report, you need to contact dispatch in some manner and get the dispatch times, so the times you left, the time you got on scene, the time you got back to the hospital is all accurate. So our patient information, we're going to give a lot of that same information we gave at the hospital. Age, sex, that, but we're also going to include address, phone number, date of birth, weight of patient. We're going to at least do a guesstimated weight, but if we know the weight, we're going to include that. Race or ethnicity to the best of our knowledge, and then any billing or insurance information that we have. Okay. So during the call, we're going to gather some information, and this also needs to be included. So our general impression of the patient. We're going to do a narrative. A narrative is basically a written story about what happened. Now, there's different formats you can put this in. I like to do a chronological. I arrived on scene. This is what I found. This is what I did. And this is how they responded. Okay. Some people use things, acronyms called CHART. Others are SOAP. So they list the subjective, and then the objective, and then the assessment, and then the patient care or patient response after that. As long as you're using the same type of format each time, you'll get very good at doing this. This is probably the most important part of your patient care report, is that narrative. Okay. So we want to list things when we're talking through this about any aid that was given prior to us arriving. Such as, CPR was initiated prior to us. Then we We want to talk about their past medical history. We want to talk about what we found on the physical exam, the vital signs, if we did an EKG, what was on there. We want to list any procedures and treatments that were done, any meds that we administered, and then any other stuff that is pertinent. We also want to talk about transporting, how we transported them, what position they were transported in. If you came in, say, code 3, you would want to put that in there that you responded code 3, which shows that you recognize the importance of getting them to the hospital early. So in our narrative, the objective information is going to be stuff that's observable, measurable, and verifiable. Okay, so that would be vital signs. That's going to be patient presentation. Patient presented pale and sweaty. Patient things that the patient says. It's very nice to put that in quotes. If the patient tells you something that's pertinent, quote them. Put it in quotes in your narrative. And that makes it objective. Okay. Some subjective things, other objective things would be the scene, things you saw on scene, things you smelled, maybe the environment was very cold, it was snowy, it was raining, it was icy, that the car was on its top, those types of things, that there was extensive damage to the front end of the vehicle, those types of things are objective. Subjective are things that are subject to information. If it's hearsay that somebody tells you they think they're diabetic, that's going to be subjective. Or if the patient tells you that they only had 2 beers, but they can't stand up and they're staggering all over. Or if you suspect that they smell of alcohol. The way I word that is there is an odor of alcohol on or about the patient. I'm not going to say they're drunk. I don't know. But if I put that in there, then it says, okay, there's a chance that there's alcohol on board. So we got to be kind of careful how you word things so you're not accusing and you're not putting things in there as fact that aren't fact. But you certainly want to include everything that's important. Okay. So chief complaint, we're going to put that in. We are called to a shortness of breath. Okay. On arrival, patient tells me I can't breathe. That's in quotes. Okay. Because that is my chief complaint. Now, we might find other things as we do our assessment. Other things we want to put in there are pertinent negatives. So negative findings would be if I've got a patient that's complaining of abdominal pain, but he has no pain upon palpation, so I can touch his abdomen and it doesn't hurt. That's important to know because that tells us something big about this abdominal pain. Those pertinent negatives sometimes are just as important as the positive findings that we find. Okay, we don't use radio codes when we're writing our patient care report, and we don't use any abbreviations other than those that are posted as approved abbreviations by our agency or the hospital. Okay. Here's a big one. If you're handwriting, it has to be legible. You have to be able to read this. Okay. And here's the bigger one. We have to spell correctly. Okay. Now, given the fact that we're using medications and we're using medical terms as far as body parts and things like that, it's easy to get to have spelling challenges. I'll put it that way. I used to be a tremendous speller, but what I have noticed is as I got older and as I start to rely more on spell check, my spelling has deteriorated tremendously. So sometimes I have to go out and I have to Google or I have to type it into my text messaging thing just to see what's going to pop up so I can get the correct spelling. It is worthwhile to do that to get it correct. We all have spell check. We all have Word on our computers and utilize those. They're there for our own benefit. Okay, so we've got to be able to read it easily. It's got to be accurate, and it has to reflect both what we found and the patient care we gave and the patient's response to our care. Okay? So we're going to use our terminology that's appropriate, that the terminology is there to help us document correctly. Use it. Okay? Here's the golden rule. If you don't write it in your patient care report, then you did not do it. If this goes to court and they're like, well, why didn't you put oxygen on this patient? It's like, well, I did. Well, where is it? Well, I didn't write it down, but I did. I put oxygen on every patient that's short of breath. If it's not in there, you didn't do it, and you can get slapped with a negligence charge because of that. So write it down. Special issues, confidentiality. There is a law called HIPAA, and it's the Health Insurance Portability and Accountability Act. This is a federal law. This is huge. Okay? Basically, it says, I cannot release any patient information to anybody for any reason at any time unless it's subpoenaed into court to do it, it's to an insurance company for billing purposes, or it's to hand off my patient care to another medical provider who will be assuming care of my patient. So I can talk about it with my partner who's involved in patient care. I can talk about it with the person that I hand care off to. That is it. Now, the fine for this, if the first time offense of creating a HIPAA violation is a $50,000 fine. Just this week, I had we just released a student from the paramedic program for a HIPAA violation. The student was 4 weeks from completion. But what this student did was went into an intensive care unit at a hospital, and there was a 1-month-old baby in the hospital that was there with a fracture. This fracture, fractures in 1-month-old babies are frequently considered abuse, or at least abuse is a consideration because 1-month-olds don't, like ride motorcycles and jump out of trees. So and long story short, she knew the parents. She left, went out into the bathroom, got on her phone via Facebook, contacted the mom and said, oh my gosh, I'm up here with your child, and proceeded to have a conversation about her concern that the mother was going to be looked at as being abusive if she didn't come up here and spend more time with the child, and you need to come up here because they're thinking that your child is abused. That is a HIPAA violation. The hospital came back and said, we had this huge issue. The parents then came and confronted the nursing staff, and the nursing staff said, what are you talking about? And the parents said, she told me that you said this, and it was verified that she did that. I'm sure she had the best intentions in mind, but had she been working for that hospital, she would have been fired on the spot. Because of the HIPAA violation and the hospital's liability to that, the question whether we were going to even have students come to the hospital at all became an issue, whether they didn't even know there at this point in time, we're not allowing any students to come in until we can figure out how not to ever have this happen again. So all of our students' ability to do internship and clinical time stopped. We had to have meetings. It was meeting between the hospital attorney, the college's attorney, the medical director was involved directly. It was huge. So according to this law, you really can't even go home and talk to your family or your spouse about what you see at work. So just zip it. It's just much easier that way. Other legal issues are patient refusals. High liability with these guys. When they just refuse care, number one, we have to make sure that they are competent to do so, and they are not under the influence of drugs or alcohol to be able to refuse care. And they have to be a legal adult. So children cannot refuse care, teenagers cannot refuse care, people under the influence of drug, alcohol, or with an altered mental status cannot refuse care. If they do, hold on. There are forms that they're going to fill out, so they need to sign, and it needs to be witnessed. A great witness for a patient refusal form is a family member of that patient. Okay? If you don't have a family member, law enforcement would be your next great witness. I try to find somebody else besides my partner to witness this with me, because in a court of law, that my partner and I kind of appear to be one unit. That sure, we're going to back each other up. But if I can get a family member of the patient to sign it, that's a pretty good backup for me. Okay. Falsification. Okay. What we don't want to do is ever falsify our documentation. So we don't want to do anything that looks like we're covering up. So if you create an error on your written report, then draw a single line through the part that you want to correct, one single line, and initial right above it. Okay. We don't want to make it illegible. We want them to be able to see what we are deleting and what we're adding to it, so it doesn't appear that we're trying to falsify anything. If we finish our report and realize that we've forgotten something, then we can go in later and add more to that. So if we need to add something, we can go back in and I just put a note that says late note, then I add my information and I sign it. One thing you want to do is always, especially with paper reports, but also with electronic reports, is get your signature at the end of it, so that this is the end of the report, here's my signature and my credentials, and I'm done. That way, if anybody tries to add anything to it, it's very obvious that it was done after the fact, and or by someone else. So if you always get in the habit of signing everything you do or initialing it, then if it's not initialed or signed by you, it's going to cause a red flag that this is abnormal and it perhaps was added by someone else. So if you are recording something you forgot to do, it is okay to go back in and put that late note in there and get that done. Better to do that by far than not to do it. Okay. Oops, hold on here. Okay. Now, MCIs, multiple casualty incidents. These are, we'll learn more about this in trauma, but MCIs are basically a situation that involves enough patients that it's going to overwhelm our system. So if it's me and my partner and we have one ambulance and I have 3 patients, that's an MCI because I'm going to have to call in additional help. If I've got, routinely another ambulance that can be dispatched out. So these are, the severity of these incidents depend on the agency that's responding. I think there are incidents that will always be overwhelming to a system, such as maybe a school bus wreck or a plane wreck or a school shooting or a grain bin explosion. There's lots of different things that may potentially, even car wrecks involving maybe 2 or 3 cars, 4 cars, you would have a significant number of patients. So the care and evaluation of these patients are probably going to be administered by different providers within different departments, perhaps at different times and perhaps even in different locations. These patients may not all go to the same hospital. They may be dispersed out to different hospitals so as not to overwhelm the hospital system. So this makes documentation a little bit difficult because obviously our communication is going to lack here and just tracking these patients. So when we have this, it's going to be up to incident command, the incident commander, and you'll learn more about that when we get to our trauma and MCI chapter. But there'll be one person that's in charge, and you'll need to coordinate and get together and see if you can put all the pieces of this puzzle together after the fact and make sure that your documentation is all correct. Because I may actually be the first on scene, and so I'm going to quickly triage and look at these 5 patients we have and try and establish who needs to be taken care of first. So I might take these 2 patients and triage them and hand them off to another paramedic that's there, and then take care of these next 2 that are kind of hurt, and maybe put some oxygen on them and do a little bleeding control, and then hand them off to somebody else and not really know where they go once I let go of them, and maybe not have super clear accounting of what was done. The people that take them from me not really know full well what was done before they got there. So there is a greater element here for our documentation to not be as clear and concise as we would like it to be. So we need to get together afterwards and see if we can put those pieces together. Okay. Other things that we need to think about reporting. If we're exposed to an infectious disease, let's say you take care of a patient who is AIDS positive, you need to report that. If you know that patient's AIDS positive or potentially AIDS positive, that information needs to be reported to the people that you hand it off to, because there is a risk of exposure here, and you want to make sure that risk is minimized to anybody else. I was actually exposed to a patient who had active AIDS. I had a significant exposure along with 2 of my department members, and there was a report on that. There was a lot of follow-up care. Big thing for that is the insurance company wants to know, because those exposures require a lot of extensive follow-up care to make sure that there's no issue that needs to be dealt with in the future. If you yourself or another of your EMTs are injured, that needs to be reported. There will be an accident report form that needs to be filled out, because that's going to have implications for your treatment, but also who's going to pay for that, whether it's workman's comp or insurance or what. If you get into a hazardous or unsafe scene, you need to report that. It needs to at least go into your documentation and be reported to your supervisor, because we would definitely like to make that not happen again. Okay. If you have a patient that you feel like really needs some referral to a social service agency, like maybe you've got somebody that you feel like is really, really going to benefit from maybe a support group for maybe they traumatically lost a child, and they're really, really having a hard time dealing with this. Maybe getting them referred to an agency that can help them find a support group for that. Or maybe you've got a mom who gave birth to a child, and the child has autism, okay, and she's really struggling, and she's confided in you that this is the hardest thing she's ever done, and sometimes she just doesn't know if she can do this anymore. Maybe get her in connection with someone that can help her work through that. The other thing we need to think about as EMT or medical providers, you are mandatory reporters for child and elderly, dependent elderly abuse. So if you remotely suspect child abuse or abuse of a dependent elderly person or dependent adult, they don't even have to be elderly, a dependent adult, so somebody that's not able to care for themselves and they rely on a guardian to care for them, or at least partially care for them, and they are being abused either physically, emotionally, sexually, or financially, we have to report that. There is a specific report form on DHS's website, You need to go in and complete that form. You need to get that done within 24 hours. And you also need to report that to the ER staff when you drop the patient off. Reporting it, I actually called DHS specifically and talked to them because I wasn't sure what the process was. I've heard so many times that reporting it to the physician is enough. When I talked to DHS, they were very adamant that you have to go and complete that report with them as well. So click on DHS's website and jump on there and find where that report is so you know where it is if you ever need to use it. All right, that's it for communication. I probably told you more than you needed to know, but hope you got some good out of it, and we will visit with you soon. Have a good day.